Okay, health promotion programs, the third prevention technique. So what's this all about? Well, you've got some references in your A2 text, page 192, but also Pennington. I'm going to refer to Pennington because there's a nice section there which I think is much clearer than our copy of our A2 text. Okay, so I'm going to refer to that. For some of you, you've got it on a separate handout. Some of you will have it included here. Okay, so you'll find it anyway. It's the Pennington material. So the principle behind this is that it's about education. Prevention is better than cure, and it's about educating people, for example, to have a healthier lifestyle, maybe through exercise, through better diet, also through reducing their intake, their smoking or drinking or substance intake really, and use. Okay, so NHS have programs on this, but also schools and youth service also have programs. And the principle behind it is to get people to take control, right? They are in control of their own health. They can improve it. And obviously, the earlier you do this, the better. And that's why schools are involved. Okay, so we've got here includes health education in schools. So the idea is it's helping people to increase control, take control over their own health and improve it. The thing to remember is it's aimed at everybody. It's not just those at risk that we've talked about before. Okay, and you know it can happen in various settings. So yes, we've talked about schools, we've talked about NHS and hospitals and places like that. But also there are companies who have taken this on board. So Johnson & Johnson, a big pharmaceutical company, for example, had a program, Live for Life. So J&J basically are really promoting healthy living with their staff. And you know, companies will maybe give gym memberships to encourage people to exercise better, but also have programs to help people stop smoking. Maybe it's also to educate them in terms of diet and things like that. So programs for young people. Really, the programs came out on why do young people, why does anyone have unhealthy behaviour? So school programs tend to focus on things that we've covered before, like peer pressure and social norms. But I'm just going to refer now to the notes from Pennington and talk a little bit about that. Okay, so I've summarised them for you. You might want to just annotate, add in a little bit more. There might be a little bit of annotation here that you had at the beginning. Okay, and so you can pause and go back and just make a few notes if you like. Health promotion from Pennington then. Okay, 3 main factors. We're going to refer to the individual, the interpersonal, and the community. All right, so individual it is really, you know, it's very logical. It's about that one person and their habits, their behaviours, etc., etc. We know habits are very hard to change. Somebody has to be very motivated to change those. And in order to do that, they need incentives. They need reasons for change. And some of the incentives could be educating them about the benefits of a healthier lifestyle. Okay, so that could be provided by, you know, different health educationalists, different health experts really. Okay, giving them the incentive by saying, you know, you need to change your diet, you need to change your exercise routine, and you're going to get better results and you're going to have a much happier lifestyle for X, Y, or Z reason. So individual factors. We then have the interpersonal, and that links in with social factors. Now, we already know that family and friends are really strong role models. And actually, as you know, that in order for somebody to change, they may need to change their friends. If we think back to that young lad who was very heavy cannabis user, and you know, when he went home, he was hanging around the same people. They encouraged, you know, he'd already been in a mental institution, and they encouraged him, you know, because he was hanging around with them, he started to smoke cannabis again, and obviously went back, had a massive psychotic episode lasting about 3 months. When he came out, he was told he could not smoke any more cannabis, and he was determined not to do it. But very difficult if all your friends are still linked in with that. Okay, and that's where you guys could include social selection. You know, deliberately choosing people who are like you. So unfortunately, you're bound to hang around with people who are cannabis users, and maybe the interpersonal is saying, well, maybe you have to rethink that. Okay, it's tough, but maybe you have to rethink it if you're going to have a life. Third one is community factors. So that is a health promotion and education that takes place in their specific community. And what this is saying is that something that's very specific to that individual and very local to that individual is going to be better than a national campaign. Okay. Okay, so health programs are really specific intervention to try to encourage somebody to have a healthier lifestyle. Okay, so better could mean various things, so we should say healthier lifestyle. There are 4 main methods, and again, this is from Pennington. Okay, the idea here is to prevent and also reduce substance abuse. So the first method is information giving. So what do these people need? Well, they need information, and it could come from the media. Okay, it could come from just the internet or medical professionals, and basically it's providing information about healthy diet, exercise, but also medical conditions that are associated with that substance abuse. So providing information. Now we in class are going to look at real examples of those that we can add in. You don't need to do that for the moment. Secondly, information to motivate. Okay, probably what I'll do is that, and that's a little bit easier for you. Information to motivate. So certain information can motivate a person to want to be healthy. We know already, we're learning a little bit about communication, and we talked a little bit about that with fear arousal and aspects like should we be who is our target audience? Are we talking about specific genders? Will the information be appropriate to both girls, males and females? Should it be one-sided or two-sided? You know, at what point should we give the real information we want? Should we go in gently? Should we just hit them hard? Should we have fear-arousing material? That sort of stuff. So we're looking at the information to motivate them. And what this is saying is we should be looking at how we present that information. So you've got examples of Leah Betts, and how that some people criticised the parents for that because they were presenting just very much a one-sided argument and implying that if you took an ecstasy tablet, then you would perhaps have an unfortunate, tragic reaction like poor Leah did. Other people say that actually we should be presenting both sides of the argument depending on your audience. Okay, so we have aspects like that, but also very personal advice, very specific advice. It tends to be more motivational than something that's very general, and that makes sense because if you can relate it to somebody individually, it's just going to be more logical for them. They're going to be able to relate to it better. Okay, the third one we've got is motivational interviewing. So an interview on a one-to-one, again, where you are looking at that individual's resistance. How much motivation have they got? What is their motive to give up? Or what is their motive to drink or to smoke? And actually that's important, really, getting an inside information on that individual. If we can find out more information, it's much easier for us to identify what that person needs to do to change. All right, how easy is it for them to change? What support do they need? So it's looking at all of that, and that one-to-one can be very useful. Behavioural techniques as well. Actually changing whatever the unhealthy behaviour is and trying to put in something that's much more healthy. Maybe we might use rewards. But again, those rewards have got to be specific to that person. If we've got general rewards, today I used sweets in my lesson with my year 12s just to motivate them to get something done. Well, a couple of them can't eat sweets. A couple of them are vegetarians, and it wouldn't work for them. And some of them wouldn't be bothered about sweets anyway. They want TCs or they want some praise or whatever. So we need to see what is the best for those individuals, and try and find something that will motivate them individually. So in general, what these programs do is they look at these elements of persuasive communication. Okay, who's giving the information? Are they somebody who's what we would say is a credible or an expert provider of information? What is the message? Is the message appropriate? Okay, what are the experiences of the audience? So all of these things with persuasive communication are really very relevant. Okay, and we're going to now look at one of these programs. Okay, and it's called DARE. So what is DARE? Okay, DARE actually stands for Drugs Abuse Resistance Education. Okay, and originally the DARE program was started in LA, in Los Angeles. And originally it was given at the end of primary school, so roughly about 10 or 11-year-olds, in the form of 17 weekly lessons of an hour, but it was given by police officers. Now it's been extended to older age, but then when it first started it was, as I say, done by police officers, just really for the 10, 11-year-olds. Okay, and the idea was that's what I want in the process was 17 weeks, an hour by police officers. Okay, what do they cover? They covered information about drugs, so giving those children information about drugs. They also taught them decision-making skills, like we've been covering a little bit with your social inoculation. Also trying to build their self-esteem, because we know that actually those with lower self-esteem are likely to conform more and things like that. So we could bring that in there, okay? But also giving them healthy alternatives to drugs. So this sort of information is really like your social inoculation work, okay? So this program. They use various different techniques, various teaching methods. So the typical ones, a few lectures, discussion, providing some audio-visual material, a bit of role-playing, using a workbook, work exercises, and so on. Okay, so very traditional methods really, and as I say, done by police officers. So we've got some information on what DARE was, all right, the methods used in it, lots of lovely detail on it, but then we have to go and go on to evaluate it. How effective was it? And the ENIT study was investigating this. The ENIT study is on page 193 of your A2 text. And the idea behind it, the aim we've got there, was to compare the effectiveness of DARE, all right, to compare it with other programs, some of which were more interactive, some of which were less interactive. And what they were looking at specifically was things like the end of these programs. Remember, DARE was 17 weeks. At the end of it, and that's quite a lot of investment of time. So at the end of it, they wanted to see how much knowledge the children came out with. What were their attitudes? What was their self-esteem like? What were their social skills like? How much involvement did they end up with the police? And obviously, at the end of the day, what was their drug use? Okay, so the ENIT study evaluated 8 DARE projects with 25 other programs, which were, as I say, either more or less interactive. So what did they find? That's the method we've covered there. What were the results? What did they find? Right. DARE, they found, was most effective on things like their knowledge, and also their social skills. But actually, it wasn't very effective on their drug use. In fact, it didn't seem to be very effective on how much material how many substances, how much substance they went on to use. Okay, and they found that the most changes were actually for tobacco. They also found things like DARE was actually more effective than the non-interactive programs. But if the other programs were more interactive, they were more effective than DARE. Okay, so in other words, what they concluded really was that the more interactive these programs were, the more effective they were. And that's why, if we're going to use a social inoculation program with, let's say, year 9s, we really want to, it's no good just telling them stuff. We want them doing the talking, them doing the pronouncing that they're not going to smoke, and so on and so forth. Okay, so it's got to be really interactive, them doing the role plays, etc., etc. And the more we do that, the better. So what else do we want here? The evaluation. The other key point we can have as an evaluative point is that DARE was taught by the police, and the other programs were taught by teachers, okay, trained teachers. Now, the police would be really expert in terms of their authority and probably their knowledge of these substances, but possibly there's a comment that perhaps they weren't as good at delivering the material, and perhaps the teachers, who had been trained on delivering materials would be better. So DARE is very traditional method, use very traditional methods as well. So maybe there were issues with engaging the students there, possibly. That's an evaluator point. So your second point there is DARE in the UK. Basically, they have opened up programs like DARE in the UK by charity institutions, mainly for primary school, but also for 11 to 13-year-olds. And it also includes little programs for parents and carers. You guys, that's a bit of fact, DARE in the UK. But actually what you could comment on, you could make that a positive by saying because of results of DARE in LA, they have introduced it to some extent and to some effect in the UK by extending it slightly. So make it a positive point. Okay. You've also got point 3 with this meta-analysis. Meta-analysis is only putting together small studies to make them one big program, if you like. So meta-analysis of 37 teaching programs, again in the USA, by Tobler. Tobler was one investigating it. And basically they found the same results, that the more interactive the programs, the better, really, okay, in terms of things like social skills. And if they were non-interactive, then they weren't as effective. And that was in reducing use of cannabis. So that's probably worth a mention. We now also have drugs guidance for schools. So this was updated in 2004. And we now have programs or policies really included now to educate in schools. The idea here is to increase knowledge, to develop their personal skills and resistance to peer pressure, and also to do some work on exploring their attitudes to drugs and to users and things like that. Okay, if you have a look on page 194 of your text, there are different recommendations. And basically with this, they also say that drug education is most effective when, and there's a whole series of things, but maybe just have one or two. But I would say probably, the recommendation that's most, if it's provided by teachers with help from experts and health professionals, that seems to be the most effective. Also, if it's integrated in part of the curriculum, so it's definitely going to be covered, like part of science program, part of PSHE, then it will be more effective. So there are recommendations. And again, this is really saying this is it. This is the information applied in the real world. And therefore, it's valid. It's what happens. It's accurate information. It's what's going on in schools today in the UK. So that's got to be a plus point. You've also got notes on Project Charlie. Okay, and this is a project that's been used in the UK, so it's probably worth you making reference to. Charlie stands for Chemical Abuse Resistance Lies in Education. And actually it's a very similar program. Gives you a lot of AO1 details. So for example, it's primary school and early secondary school, 14 lessons. And again, it's providing knowledge about drug use and misuse, what's illegal, what's illegal, consequences of drug use, understanding peers and media pressure, things like that. Things like we've just been covering in our social inoculation. So very similar thing. And the idea again is interactive teaching methods. Okay. And 1996 they did an evaluation of this. A study of Project Charlie followed up children who'd received this prevention program in schools in 1992. And the results showed less experimentation with tobacco and drugs compared with the control group who hadn't had the program. So from that point of view, it's probably worth you commenting on and saying that it was showing that it was effective. And then we had the evaluation of these programs. Okay, so with this one, the evaluation, for example, Charlie and things like that, 2006 did a survey and found between 55 and 60% of students recalled having had a lesson on smoking, drinking and drugs during the last year, 55 to 60%, who could remember having had a lesson. And most of them said that actually that lesson, or those lessons, had increased their knowledge and had helped them to be able to say no. Many of the students overestimated the proportion of their peers who smoked and drank. Okay, so the perceived norms comes into this. Perceived social norms are very different to real ones, so they overestimated what was being used. And 96% of schools reported they had a drugs policy. I would say now that I would think 100% of schools have to have a drugs policy. And in over 60% of those schools, the 96%, 60% of them, students had helped with the development. So we've got, we know what this is saying is how effective this is, that children are actually being used to help write policies. They're aware of the policy. They think the policy is working, as in it's helping to reduce drug use. We've got example there with the Scottish one. Scottish drug education involved a study with 1,200 students. Okay, and the results of that reported improvements in drug-related knowledge, but not necessarily changes in attitudes or behaviour. So it comes back to this psychological thing we've got, where we can do work to change people's attitudes, the knowledge part of their attitude, but changing the behaviour is another factor, and the two are different. Okay, remember cognitive dissonance. Often we'll try, if we've got the knowledge, it will change the behavioural bit, but not necessarily. Okay. The next point really is just saying that lots of peer mentors are used in drug education. Okay, and this is, we've talked about trying to show them how to resist peer pressure, educate them on that. Peers can be very, very positive. So social learning, if you're observing the right people, then obviously that's going to be very good, and those peers will have credibility as communicators. So they can also help to get rid of this idea of what social norms are and the perceived norms. Everybody's doing it. Okay, so they can actually be used to help dispel those myths. So last point then, we've got your last point is health promotion and what that involves. And this final point is really very interesting, because it says here a survey of 31 public health leaflets in the UK designed to encourage sensible drinking found that they used fear arousal about negative physical consequences of heavy drinking. But the thing is, none of them encouraged the readers to abstain or to drink very moderately. Okay, so it was just telling them, it was just using fear arousal, saying what would happen if you drank to excess. Therefore, if you remember what we had before with Witt's model, efficacy was ignored. The leaflets were not telling them how to abstain or how to drink in moderation, and that seems to be what it was needing for people to learn from that, to change their behaviour. If we provide them with ideas about control, what they can do to control, that we know will actually be more beneficial for them. If you're just using the fear arousal, it's not going to help them that much, because we know what happens. People tend to stick their head in the sand. They tend to think it's not going to happen to them. They go into denial and things like that. So we need the efficacy information in order to help the change.